Okay, so welcome to this third module of the Exotic Animal Practice course, and we're going to look at anaesthesia and critical care. We're going to start with domestic pets first of all, small mammals, move on to birds, reptiles, and then other species, other potentially wild, captive, exotic animals, and cover anaesthesia and analgesia, and then we'll look at critical care probably this afternoon, principally obviously for exotic pets. So there's a limited amount that we can do with critical care for wildlife and zoo animals, and we'll cover a little bit more about that, to be fair, in those respective modules, but they are challenging to administer critical care to for obvious reasons. So we'll start off and look at anaesthesia of rabbits. In the first instance, I guess you're all seeing bunnies, yes? There's no totally reptile practices in the room or bird practices in the room. So apologies again for teaching, I'm sure, granny to suck eggs, as they say, but it's probably worth just reiterating some of the issues and problems that can turn a successful rabbit anaesthetic into an unsuccessful one. They are prey species. They are incredibly prone to stress. And actually, when we're talking about post-operative ileus, which I know is a big concern for all of us when we're anaesthetising rabbits, one of the biggest causes of post-operative ileus is uncontrolled pain and stress going into it. So actually, in the vast majority of cases, it's not something that they're just going to develop. So I don't routinely give prokinetics to all of my rabbit anaesthetics, but I do make sure that I am considering the appropriate analgesia for whatever procedure I'm carrying out on them, and also try and minimise the amount of time the rabbit spends in a noisy ward, hopefully no time at all in a noisy ward, but at least minimise the amount of time the rabbit's hospitalised, so that we can get it in and get it out fairly promptly to minimise the stress. The other thing, of course, being hindgut fermenters, small herbivores, they need to continuously drip feed food into the digestive system. Otherwise it does have a slowing effect on the gut. So we recommend that you do not starve bunnies before anaesthesia. We obviously don't want a huge amount of dry food fed. I mean, a goodly amount of fibrous, good quality hay or leafy greens is fine. Large amounts of food are to be avoided because the stomach sits obviously on the abdominal side of the diaphragm. It's always full, and if it's over distended, the main inspiratory effort for bunnies, as with a lot of small mammals, is flattening of the diaphragm. It's not movement of the chest. They've got actually a relatively small chest space in comparison to their abdominal, and therefore they've got a large viscus on the other side of the diaphragm that's impeding diaphragm flattening. Then again, that can lead to potential problems. So they need to be fed, but light amounts of food, preferably of a fibrous nature, and try and keep familiar scents and food items. So again, you may well have identified that the rabbit is not on an optimal diet. Now, during a period when you're potentially putting it through an anaesthetic, is not the time to suddenly change its diet. You want to do that gradually. We know that in dogs and cats, you want to change over a few days. With a rabbit, it can take several weeks to gradually change them over. We don't want to suddenly withdraw their obvious food source, their usual food source, and suddenly plonk in the ideal bunny food, because they're just not going to accept it the first time around. And that in itself is going to lead to ileus and potential problems. Familiar scents, so yes, if the owner wishes to bring in the rabbit's blankie or something like that, then let them. You're not just humouring them. Obviously, olfaction is an important feature for most of the animals that we deal with, and rabbits are no different, and so familiar scents and odours are important to minimise stress. The other thing we want to look at is pre-anaesthetic examination, and this one actually is perhaps one of the most important, and routinely we want to give the rabbit a full physical examination. So even if you did not admit the rabbit, before you administer any anaesthetic, do cast your eyes thoroughly over it. We want to obviously be paying particular attention to the respiratory tract. Obviously, if we've got anything like this around the upper respiratory tract, we're bound to have something in the lower respiratory tract, they're obligate nasal breathers. So consequently, this is not a good candidate for anaesthesia unless it's an emergency procedure. Similarly so, I always look in the ears of rabbits as well. Look right the way down the bottom as far as you can. Appreciating small bunnies, the horizontal ear canal is narrow but short and difficult to visualise, almost impossible to see the tympanum in small bunnies. But actually I always have a look in the ear, because if I can actually see pus at the bottom of the ear canal, clearly that tells me something about the health of the rabbit. It's got middle ear disease. And as I'm sure you're all well aware, middle ear disease can lead to vestibular disease, and I have had rabbits in the past through bitter experience where they did not have vestibular disease, obviously clinically, before they went through the anaesthetic. I didn't check the ears, they went through an anaesthetic, and when on recovery they then had torticollis. And that is a difficult explanation to have with an owner. They inherently believe that you've done something to the rabbit to create the vestibular disease, and technically speaking you have. But nonetheless, it's good to have that conversation up front with the owner and explain to them, okay, you thought it was coming in for a routine castration or a dental. Actually, there's something else serious going on here. I'd really rather like to sort that problem out first, because actually it increases the risk of developing other conditions during the anaesthesia. So have a good look in the ears, check them out, particularly the respiratory tract, and palpate the abdomen as well for any obvious signs of gas distension or potentially blockages. Pre-anaesthetic medications, well, the one that is frequently discussed, and we'll talk more about this in the critical care and emergency side of things, is glycopyrrolate. We know that rabbits, depending on which particular reference you look at, and some of these are quite dated, but nonetheless there is a suggestion that the majority of rabbits, over 60% of them, do have serum atropinesterases. So I guess it makes some sense. Evolution is a continuous thing. Plants develop atropine. You remember it comes from belladonna, woody nightshade, deadly nightshade, and it has parasympathetic effects. And so what we tend to get is bright blindness, you get dilation of pupils, but more importantly, as far as anaesthesia is concerned, you can get tachycardia associated with atropine, and you can get drying of the mouth and potentially other symptoms as well. So rabbits have developed atropinesterases through evolutionary means to be able to allow them to eat many plants that contain these compounds, which developed in the plants obviously as a natural deterrent to herbivores. So they don't actually work is the problem, and so when we have an issue with bunnies, and when it is a serious complaint cardiac-wise, we're looking at a heart block as our most significant and important cardiac dysrhythmia during anaesthesia. And actually when bunnies tend to just spontaneously give up under anaesthetic, it is usually because of an undetected heart block, which then goes into a full third degree heart block and heart failure. And so glycopyrrolate is a really important emergency crash drug for rabbits, and some recommend it as a routine pre-medication. So I would always have it on standby, but certainly as a pre-med there is some benefit to it. Varying different doses, 0.1 mg per kg is sort of typical. ACE promazine historically has been used. It's not been used so much these days because of its inherent inability to be reversed. It has some positive effects in the fact that it is a tranquilizer. Its negative effects are that obviously it's not very reversible, and if the rabbit already has some cardiorespiratory issues, then it can cause profound hypovolemia and cardiac output failure, and so it's not generally recommended. Fentanyl fluanazone, anybody using fentanyl fluanazone? Hypnorm? No, it's kind of fallen out of favour, which is a shame. It's still manufactured by Vetapharma. It is a Schedule 2 because of the fentanyl aspect of it drug, so it does need to be treated in the same way that morphine and other Schedule 2 drugs do. It's use recorded, etc., and locked away. However, it has some very positive benefits as a pre-med. It can be used as a full general anaesthetic in combination with Midazolam or diazepam. It can be used at a high dosage of 0.5 mils per kilogram, so it's dosed on a millilitres per kilogram basis. at 0.5 millilitres per kilogram in bunnies as a sedation. So if you're just wanting to do a light incisor trim in a stressy bunny, most of them you can do conscious, but if you've got a really stressy bunny, you can do that. Or you want to take some radiographs, you can give it this particular combination. Its positive effects are, unlike medetomidine and ketamine combinations, in a sick rabbit, it is really gentle on the cardiorespiratory system. And so it rarely results in any significant problems associated with cardiac failure. Its negative aspect is that the fentanyl is reversible. You can give naloxone, you can give buprenorphine, you can give butorphanol, and that'll reverse the fentanyl part, and so you will get a rabbit going from a deep sedation to a, you know, now upright and sort of looking at you. But the fluanazone kind of has to wear off of its own accord, and so recoveries can take an hour or so, whereas if you're used to a very quick recovery with Med-Ket plus or minus butorphanol, that you don't get that. You don't get the suddenly I'm back in the room kind of response. It takes a bit of time. So it takes a bit of getting used to. The other great positive effect of this is that whilst it doesn't seem to significantly drop blood pressure, it dilates very nicely the lateral or marginal ear veins. So if you had difficulty getting vascular access before giving the hypnorm, even a low dose at 0.1 mil per kilogram, which is kind of pre-med dosages, just takes the edge off the rabbit if you're then wanting to do a gaseous induction. Then that dosage also nicely dilates lateral ear veins. So actually you can then get an IV catheter in there, you've got vascular access. So it is a useful drug. I can guarantee though, because of the way that the medicines regulations from the Veterinary Medicines Directorate are currently phrased, that once the vial is broached, you've got to use it within 28 days. If you're not seeing a lot of bunnies with this, it could be an expensive option to choose, but I still do use it, and I still find it a useful combination. Medetomidine, obviously, on its own has been used, 0.05 to 0.1 mg per kg, but often is combined with butorphanol, or potentially used straight and just skipping the pre-med and going straight to Med-Ket combinations as a straight induction. Dexmedetomidine also, there's several papers on its use, and obviously in milligrams per kilogram is usually used at half the dosage. The confusing way that they've formulated the preparations, you'll know that still works out at the same millilitres per kilogram because they've actually reduced the concentration of the dexmedetomidine from 1 mg per mil to 0.5 mg per mil, but you'll understand why. Midazolam, though, can be combined with it 0.2, 0.5 mg per kg, depending on how stressy your bunny is, or butorphanol, and that is quite a good routine pre-med for healthy rabbits. So ones that have no underlying cardiorespiratory disease, ones that have no hypovolemia or underlying kidney problems. Remember, medetomidine has several dysrhythmogenic effects, particularly where there are potassium imbalances. So you've got rabbits with diarrhea, you've got rabbits with renal failure, then medetomidine should be used with extreme caution. It also shuts down blood supply to organs like the kidneys. Old bunnies have chronic renal disease quite commonly. It's not an unusual diagnosis, as I'm sure Richard has explained to you in the rabbit lectures. And cardiac dysrhythmias as well. Cardiac disease in rabbits is surprisingly common. Atherosclerosis is common in rabbits. They have been used historically as a model for human atherosclerosis. So they will develop aortic outflow, narrowing, damage to heart valves with age is common. And they also can suffer from several other conditions, so mediastinal masses, thymic lymphoma and so on in older bunnies, all of which can affect vagal tone, create dysrhythmias. And as I say, heart block is by far and away the most common dysrhythmia in bunnies, and one that we do, if you've got a bunny that is of concern to you, then during anaesthesia we do recommend that you have an ECG on it, or at least have somebody very attentively listening to heart rates and rhythms. But an ECG is a useful thing where, should we say, some of the more challenging anaesthetics in bunnies are concerned, because if you pick up on the heart block very quickly and you've either pre-medded with glycopyrrolate or you haven't pre-medded, then you need to be administering glycopyrrolate very quickly in order to stop the progression. Remember, first degree heart block is just that elongation between the P and the QRS complex. That's what you tend to see in the first instance, and that's what you may you may start to hear before you actually get cardiac failure. Second degree is where you're missing, you haven't got a P wave for every QRS complex, so that it is progressive. And then third degree is where there's complete disconnect between P waves and QRSs, so there's a complete block between the upper chambers and the lower chambers, and what you're getting then is just escape complexes, so usually dystrophic looking QRS waves coming through. That is incredibly difficult to reverse, third degree, so you're wanting to administer your parasympathetics, your glycopyrrolate when you're at the first and second degree heart block stage, if at all possible, to ensure success. For general anaesthesia, as I say, there are a number of combinations that can be used, and these are some injectable combinations. Historically, as I say, Hypnorm, which is this combination here, so the trade name's Hypnorm, fentanyl fluanazone, 0.5 ml per kilogram, as we said, could be used on its own as sedation, but you can also combine with drugs like diazepam at 2 milligrams per kilogram, or midazolam. Midazolam if you're giving it IM. If it's diazepam, then usually they recommend giving it intraperitoneally. So we generally tend to use midazolam and go IM. But 0.3 mils per kilogram of Hypnorm plus 2 milligrams per kilogram of midazolam would provide full general anaesthesia for about 45 minutes. And it's quite a gentle, quite a nice anaesthetic, but again, if you're used to triple combination, Medkep, butorphanol, recovery is not instant. So when you give the reversal, they don't just roll over and get up. You tend to have a slow recovery. It tends to be gentler on the cardiorespiratory system. We tend to find also on blood pressure, it tends to be a little bit more forgiving. But recovery is longer. They're going to be in hospital a little bit longer, so you have to put that into context. And also, as with all injectable combinations, you have to be aware that whilst part of it is reversible, the fentanyl, in an emergency situation, the other bit of it, fluanazone, is not. And if you've got midazolam or diazepam, then unless you've got something like flumazenil on hand, which relatively few practices have, they're difficult to reverse as well. And even with flumazenil, in my experience, actually diazepam and midazolam are somewhat difficult to reverse. It's not quite the same as giving atipamezole for medetomidine. Medetomidine, in older textbooks, you will see a whole bunch of different dosages that have been used with medetomidine. Older textbooks tend to state much higher dosages than I think are currently being used, and certainly much higher doses than I would be happy using. In fact, when I first started in practice, the recommended dosage for medetomidine and ketamine in a rabbit was 0.5 milligrams per kilogram of medetomidine per kilogram, and a ketamine dosage of 35 milligrams per kilogram. We did lose some rabbits, I have to say, during that particular procedure. That was taking a very large hammer to crack a very small nut. So I would not recommend that particular combination there. There has been, interestingly, there's been an increasing trend for trying anaesthesia intranasally in varying different species. We'll come back to this in birds, where it's been tried in parakeets and things like that, squirting it up the nose. I'm not entirely sure that I understand why this obsession is. I mean, I can sort of understand that putting a large needle in a small rabbit is not necessarily a terribly pleasant thing to do, but it's quick and it's fast, and if you're slick and you're using a relatively small gauge needle, you know, these are aqueous solutions, it's not a big deal, these aren't large volumes. So I'm not entirely sure, whereas sticking something up a rabbit's nose is actually quite aversive. If you've ever tried to swab a rabbit's nose with pasteurellosis, or you've ever tried to pass a feeding tube in a rabbit, you have to sedate it or give it at least, first of all, a really good spray of local anaesthetic into the nasal passages and give it 15 minutes and then come back to it. They don't like it. I'm not surprised. I mean, we don't like having things shoved up our nose. So, and this particular publication, shall we say, peer-reviewed publication, also found that if you kept them in dorsal recumbency, some of them died. So I think the dosage was possibly a little bit out there, and I think the management of airway, which we'll come back to increasingly with rabbits, is vitally important. If you're doing anything with a rabbit and you are anaesthetizing it, secure an airway. This is the most important thing, because some of them do just stop breathing. And that can be obviously a challenge, but if you've got control of the airway, it's sortable. Not if it isn't. So I put this one in here for interest. It's a fairly recent publication. These sorts of combinations here, 0.1 mg per kg medetomidine, 5 mg per kg ketamine with butorphanol at 0.5 mg per kg, are typical with triple combinations. And medetomidine, butorphanol, buprenorphine, midazolam, butorphanol, buprenorphine, followed by alfaxolone, is also a current trended, and alfaxolone was mentioned in a second, is actually now, obviously, as I'm sure you're all well aware, licensed in rabbits. Hypnorm actually is also licensed in rabbits. So it's an interesting situation with Hypnorm because it's now become slightly less commonly used. Technically speaking, it's been around since pretty much the early 80s, and for rats, mice, guinea pigs and rabbits it was a licensed sedation, and then if it were combined with midazolam or diazepam it became an anaesthetic. But because the midazolam and the diazepam weren't licensed, you couldn't say that the actual anaesthetic combination was licensed in rabbits. So it's another one of these wonderful grey areas that we sort of float around in under the cascade. VMD are usually pretty pragmatic because these are non-food producing animals and therefore they're fairly okay about it. But actually, if we're looking at what is a licensed anaesthetic for rabbits, there is no whole combination of drugs that technically is completely licensed for rabbits unless you're going just for gaseous isoflurane anaesthesia, which in itself can be somewhat problematic. I mentioned for completeness sake these two here, or these three here I should say, but again I don't recommend them. So older texts, xylazine and ketamine, if anybody's still using xylazine, you can't reverse it that easily. It's not a great drug. Marini suggested that actually you've got quite a lot of myocardial hypoxia associated with it. Clearly not a good thing. So consequently I would scrap that particular one. Propofol, yes, you can induce anaesthesia with a continuous total infusion of propofol at 0.7 mg per kg per minute intravenously or intraosseously. You can induce at 10 mg per kg IV if you can get a lateral ear vein. But you do get, even at slow induction rates, significant bradypnea and actually in a lot of cases apnea. So again, personally speaking, why put yourself under that amount of stress? I'm not entirely sure. You've then got to get secure an airway, effectively. So you've done it, you've induced it, oh, now I've got to actually get a tube in it. I'm not sure that that, in a busy practice, is a good thing to be doing to yourself. It's putting the rabbit under a lot of adrenal stress and putting you under a lot of adrenal stress as well. So personally, I would leave the propofol out. And similarly, a ketamine propofol combination, ketofol, 5 mg per kg of a 1.1 to 1 mg per kg ketamine propofol solution has also been used. There's a couple of publications out on that. Smooth IV induction, but profound apnea again. So it's possible to induce anaesthesia. The anaesthetic, providing you can secure the airway and breathe for the rabbit, is fine, but you've got to secure an airway and breathe for the rabbit. Now, in general, we would want to be doing that anyway, but I don't think you want to put yourself in a position where you absolutely have to, because you're going to lose the patient. Alfaxolone currently obviously has a license in bunnies. Interestingly, before it received a license, one study at 3 mg per kg by Gill et al. In 2012 showed significant cardiorespiratory depression and adrenal stress. I mentioned that just in passing. It has received a license for its use, but at 4 mg per kg IV, with a pre-med, and the pre-meds that they recommend are medetomidine and butorphanol, or medetomidine and buprenorphine, or potentially midazolam and butorphanol, or diazepam and butorphanol or buprenorphine. So personally speaking, therefore, if you've got a slightly more debilitated rabbit, I'd go with a benzodiazepine and a partial opioid, gentler on the cardiorespiratory system, nice effect on the bunny, a little bit more difficult to reverse because you get a little bit of a hangover effect of the benzodiazepine. If you've got a fit, healthy bunny, then I would go with medetomidine plus a partial opioid, because you can then reverse the medetomidine really quickly with the atipamezole, and I guess if you get into trouble, you know, you can do that anyway. But I would avoid using medetomidine wherever you have an elderly bunny with questionable renal function or heart issues. In those two cases, I would certainly try and avoid an alpha-2. As I say, with a pre-med, 4 milligrams per kilogram given intravenously, as I'm sure anybody using this currently, alfaxolone? Okay, So I say it does have a license for bunnies. They recommend you give it slowly, so a quarter of the dosage every 15 seconds. So this is a real slow induction because, again, it does produce apnea. At this sort of rate with a pre-med, it really does cause apnea, but if you don't use a pre-med, then it's a slightly higher dosage of 5 milligrams per kilogram, but they are recommending you do intubate in these cases because of the risk of apnea. So again, you've got a bunny that you know has potentially historically been a challenge to intubate. This is maybe not the anaesthetic combination for you because you're putting yourself in a lot of stress and potentially risking the patient. If you're pretty comfortable with the technique, and we'll look at a couple of other options later on, then okay, fine, I would use it. It works really nicely. But we're talking about really giving you a short period of general anaesthesia, about sort of 10-15 minutes. You're going to need to then keep the bunny either topped up with the same sort of medication, or you're looking at putting it onto gaseous anesthesia to continue. So in most of these cases, we're kind of using this not so much as a full general anaesthetic, we're using this as an induction agent, as we would more typically use it in a dog or a cat or a reptile. So to maintain, we obviously have two main gaseous anesthetics that we're currently working with. Both have benefits and minuses. Both are obviously closely related. Isoflurane, you should be aware, again, and it depends on the formulation of isoflurane, but some of these are licensed for use in exotics, whereas sevoflurane currently has yet to receive a license for use in exotics. So we should be aware of that and therefore be prepared to justify the use of sevo over iso. Personally speaking, I think that is justifiable. I think sevoflurane, I think most anaesthetists, and I'm not an anaesthetist, I'm just a vet who does anaesthesia, but as most anaesthetists would back you up, that sevoflurane is a superior gaseous anaesthetic, particularly for mammals. We have some issues with reptiles, but with mammals, it works really nicely. The great advantage of it is that potentially you could use it without a pre-med because it's not as irritant as isoflurane, so you could go straight for gaseous induction. My favourite technique with gaseous anesthesia is to use wherever possible a pre-med, just to take the edge off the bunny, and then to do face mask, not plonking the rabbit's head fully in the face mask, but just loosely pointing the head of the rabbit into the face mask, and then using stepwise induction with either isoflurane or sevoflurane. So give them oxygen for a couple of minutes, 100%, get them nicely pink, and then start 0.5% or 1% if you're on the Sevotec at a time for a couple of minutes if they're still breathing very nicely, then go up again another % or 0.5% if you're talking about isoflurane, and keep doing that in a stepwise fashion until usually with isoflurane you're at about 1.5% to 2%, and then you're at general anaesthetic levels. Sevoflurane, you're usually at about 3, maybe 3.5%, and at that point you've lost the righting reflex. Use the pinch reflex, and we'll talk a little bit more about monitoring in a second, particularly in hind limb first of all. Remember that the pinch reflex in rabbits in the forelimb is retained to quite deep levels of general anaesthesia, so you will get a little bit of a pullback in a bunny that potentially is still okay to castrate or to spay. You'll get no pinch reflex on ears, you'll get no pinch reflex on toes or tail, but you may just get a little bit of a pullback on the forelimb with a deep pain pinch. Depends how hard your pinch is, I guess. But there is a local reflex arc with the forelimbs in bunnies, which can still give you a forelimb withdrawal. Isoflurane, straight face mask on its own is quite irritant, and we generally don't recommend it. Rabbits do breath hold, so I wouldn't go storming in, with a full 5% isoflurane and oxygen on a bunny. It is likely to breath hold. So give it a pre-med and do a stepwise. Sevoflurane, you may be able to do that. I generally go at 4%. You find at 8% it is still irritant, and you'll get some bunnies that will breath hold. Okay. If you've got an induction chamber big enough to get a rabbit into, then okay, fine, you could do it that way, and then that avoids the face mask right on the end of the face, which some rabbits find aversive. However, health and safety, and it depends upon your practice. Some practices I know have banned induction chambers completely and utterly because of the risks of anaesthetist and surgeon inhalation of these gases, and so face masks may be your only other option, and in which case I would start at no higher than 4% at sevoflurane. But actually, if you've got a healthy bunny, you can do a stepwise induction, and really very quickly, just notching up 1% at a time, you can do a mask induction on a bunny. So in all cases, if you're doing anything other than sedating a bunny, so if you are going for general anesthesia of a bunny, then I would recommend that you try and secure an airway in all cases. So there are three main techniques that we can use. There's obviously the blind intubation. This one is clearly difficult if the bunny is not breathing. So this is not the one to try if the bunny is not breathing in the first instance. If it's breathing very nicely, then the easiest way of doing this is to have your bunny flat in sternal, so equally balanced right and left, to pick the head up if you're right-handed with your left hand, and just gently elevate the head so that the forepaws are flat to the table and the head is in a normal position. And then use your ET tube and use the curve of it to insert the ET tube just to one side of the incisors into the midline, and use the curve of the ET tube to direct it to the back of the throat whilst listening to the end of the ET tube. And you will hear obviously the increased breathing sounds as you get closer to the glottis. The curve just pushes the soft palate up on the ET tube so that it disconnects, because obviously the soft palate is ventral to the epiglottis. It just pushes that up, and you will hear the breathing, and then just on the inspiration, insert. Now with practice, this actually becomes quite an easy technique with any bunny that's over 1 kilogram in weight. Okay, and we're generally using kilogram bunny, probably a 2.5 millimeter ET tube, 1.5 kilos probably 3 up to 2 kilos a 3 millimeter ET tube, and above 2 kilos probably a 3.5 to 4, going increasingly up. Generally these are uncuffed, so you want a relatively snug fit, but obviously you've got to get the tube in the first place. If they're not breathing, you don't have this option because you can't listen for the sounds. And generally the rough rule I have with blind intubation is I do try it, and I do still use it as a technique, and I try 3 times, and if I'm not working at 3 times, I either go to direct visualization, or if things are really not going well, I'll bail out. And that may be something else that you want to keep in the back of your mind, is don't be afraid to bail out of an anaesthetic. If things are not going right, you know, the gods of anaesthesia are telling you something on that day, listen to them. Stop. It's better to stop and call a halt to it and give the owner back a live bunny than to persist blindly with a, I can do this, and then fail. So set yourself some targets. Myself, I go with 3 strikes and you're out. If I can't do it 3 strikes blind, I will then go to direct visualization, unless the bunny is toiling, in which case I may just reverse everything and come back another day. Owners are always very forgiving when you give them back a live rabbit. They're not generally very forgiving when you give them back a non-live rabbit. Direct visualization obviously is another technique which we're obviously more familiar with in other domestic pets. It is a challenge because of the narrow airway or narrow oral cavity, I should say, that bunnies have. I personally find it easiest with the bunny on its back. So I find it easier in dorsal recumbency. Some others find it easier in ventral. You can do it either way. It's not a big problem, whichever works best for you. The advantage of dorsal as well, in my experience, is that clearly you also have, you know, kind of done a litmus test on how deep your anaesthetic is, because you think the rabbit's anaesthetized because it's, being a prey species, there's a habit of hunkering down and pretending it's, you know, anaesthetized when it's not actually. And you try and then put it fully on its back, and then there's a slight sort of tensing, and you kind of go, well, I'm not deep enough yet. Okay, so we'll just carry on with the face mask side of things, because you need the rabbit fully anaesthetized at this point in order to do this. So if you've done the IV injection, okay, fine, it probably should be fully anaesthetized. If you're doing a stepwise gaseous, you need to make sure it is. We're looking at, if you're using traditional blades, a Wisconsin zero blade, pediatric blade, you can buy rabbit-specific blades, which have a slightly longer, narrower blade with a light source right at the very end. So Paul Flecknell has designed one, Alsto used to sell it. I think it's still being sold through Meadows Animal Health and a couple of other retailers. They're quite pricey, those ones, but they're very good. A guide wire, however, to aid insertion of your tube may be necessary, because in small bunnies what you tend to find in this position is with a narrow aperture and the laryngoscope in the way, as soon as you then insert the ET tube, your vision is gone. You cannot then see the epiglottis. So it then becomes a blind insertion. So guide wires are cheap and easy to buy. Everybody sells them, and basically they are literally that. They are a small wire, sometimes plastic coated, that you, because they're thin diameter, you can see it going into the epiglottis. You insert it through the glottal opening, you hold it there, you pull your laryngoscope back out, and then slot your ET tube over the top of it, and then thread it down and use it as a guide to insert your ET tube straight into the trachea. And then if you want to reinsert your laryngoscope to confirm, but I mean usually you can then start bagging the animal and actually get respiratory movement. Clearly there is also another technique. So there's been a product that's been around for a couple of years now, 3 or 4 years now, which is the V-gel. Anybody using V-gels? Yeah, okay. So they have cat and they have rabbit ones. They've invented a couple of different size rabbit ones. The original one just had one size bunny, which kind of doesn't work. So they've now produced different sizes for different size bunnies, which makes life a little bit easier. For those that aren't familiar with the product, I hasten to add I have nothing to do with the company that manufactures this, but the tube itself has, at the end of it, it's basically inside there just a basic bog standard ET tube. It has a little side port for sampling for CO2. The larger ones have a little cuff, but what it has at the end of it is a small, soft, in the larger ones, inflatable cuff. And instead of an end opening at a shallow, at an acute angle, it has a longer opening at a shallow angle with this cuff around it. So the cuff, there is a cuff at the top here which will inflate and block the airway, but there is actually also a cuff around the opening at the bottom here as well. And the idea is it's inserted over the top of the epiglottis. So effectively this opening will now sit above the glottal opening itself. The cuff around here can be inflated to fill the back of the oropharynx. There is also a bung on this end, which is another adaptation that they've gone through with the different iterations of this product, which plugs the esophagus to stop gas going down the esophagus. So effectively it's not an intubation, it is sitting as a epiglottal or pharyngeal mask, connected therefore to your anaesthetic circuit and providing air, keeping the epiglottis away keeping the soft palate away from the epiglottis. So where it is difficult to intubate, where it is difficult to visualize the epiglottis, where you are struggling to intubate but you wish to carry on, and in emergency situations, this V-gel can be a very useful technique. It's been based on pediatric pharyngeal masks for little infants, neonatal infants, that are also tricky to intubate. It can provide oxygen and potentially therefore anaesthetic gases directly to the top of the airway. But because it is not an intubation, it has some problems. And I therefore only use this product. I think it's an important part or useful part of a crash trolley. And I think it's a useful adjunct should you wish to carry on and can't intubate for whatever reason. Personally, I prefer to intubate for 2 main reasons. The first one is, as you can see, it is entirely dependent upon the orientation of tube and rabbit to ensure that the airway is kept open. If you move rabbit from ventral to dorsal recumbency or the other way, you need to make sure that the orientation of the tube stays exactly the same. If there's any twisting of the tube, then this opening here suddenly becomes not over the top of the epiglottis and is sticking to the wall of the pharynx. And all of a sudden you've got an occluded airway, potentially. So it is problematic in that sense. You need to be acutely aware of what the orientation of bunny and tube is. You also need to be aware that This bung that goes down into the esophagus has been designed because of previous problems associated with these types of tubes. So when I originally worked in emergency clinics for a certain company that I shan't mention, we found that using the original pediatric, because these things didn't exist at the time, using pediatric cuffed tubes, which was all that we had, was problematic in bunnies because in about half of the cases, they didn't have this little bung that plugged the esophagus. In about half of the cases, you delivered gas straight down the esophagus and into the stomach. So it didn't all go down the trachea, quite a lot of it went down the esophagus. Now remember, rabbits are obligate diaphragm breathers, so if the diaphragm cannot flatten because there's now an inflating viscus on the other side of the diaphragm that's stopping it from doing that, you're actually going to be impeding the ability for the rabbit to breathe. So you're actually making it worse rather than better. So that has been improved by this bung. In my experience, it hasn't completely gone away, and that's the problem with not having, having multiple different sizes of bunnies and not having, a complete and utter range of different sizes of these tubes to fit them. Because we deal with everything from a bunny of 300 grams up to something that is the best part of about, 16 kilos. These are huge variations. It's like dog breeds. You can't necessarily get one size fits all, or indeed even 3 or 4 sizes fits all. So, useful product, I do use it. I think it's very useful in certain specific circumstances, but do be aware it does have some drawbacks, and I wouldn't use it as an easy cop-out for not trying intubation. I would go for intubation in the first instance. Circuit-wise for anaesthesia, general gaseous anaesthesia, obviously most of the ones we're using as T-pieces. You may want, for the little dwarf breeds, to start thinking about mini Baines. Mapleson Cs, this is a little Mapleson C here. So the gas comes in down this particular line here. The ET tube's connected at this point here. That's the valve. It's got a little 0.5 litre rebreathing bag. On this one you can get 0.25 litre rebreathing bags. So minimal dead space is what we're talking about for things that are less than a kilo, definitely. You may want to consider that. Clearly, if we're getting into giant breeds, then we may be looking at lax yeah, I suppose potentially maybe even a Baines as well. Right, so monitoring of bunny anaesthesia. So we have the usual physical monitoring. If you can get an esophageal stethoscope in, if you've not got too many tubes coming out of your very little bunny, then that's quite useful. It does make life a lot easier when you're dealing with a small patient where they're just big enough to get that sort of tube into them, because it means that your anaesthetist is not then, continually guggling about underneath the drapes trying to find a heart rate. Respiratory rates, generally 30 to 60 beats a minute. Heart rates in most rabbits anaesthetised, the larger ones may be in the sort of 120 to 130. Little ones may be up to sort of 260, 280. When we're talking about physical responses, as we mentioned, loss of the deep pinch reflex in the forelimbs only occurs at deep levels of general anaesthesia. So we generally tend to retain this for most anaesthetics where you're doing abdominal surgery. You will get, if you put a really deep, you put a set of hemostats across a nail bed or something like that, you will get a slow withdrawal on the forelimbs. You won't get it in the hind limbs. You won't get nail pinch reflexes in ears or tail, but you will often get it in the forelimbs. This is a bit of a problem when you're doing forelimb surgery, and generally forelimb surgery in rabbits, I tend to do a nerve block. So my preferred nerve block in bunnies is a brachial plexus block. So just slightly digressing. So if I'm wanting to do surgery on the forelimb of my bunny, I'll do a nerve block in similar fashion to that one would do in a dog or a cat. So orientate yourself with the scapula and find, it's really easy to find the suprahamate process on the scapula of bunnies is that bony bit at the bottom of the scapula. And you're aiming for that kind of point there from the cranial aspect. You're wanting to insert your needle, so get yourself a fine 23 or usually an inch long 23 in a big bunny, or if you can get a long thin 25 or 27 gauge needle for a smaller one, you're wanting to insert it to the depth of the spine of the scapula. You're wanting to aim it just proximal to the shoulder joint, and you're wanting from medial to lateral to just literally run it up along the inside of the scapula, okay? Because you're wanting to hit the brachial plexus that's in that area there. And then in a small bunny, you can put sort of 0.1 to 0.2 mils of lignocaine without adrenaline in there. In a bigger bunny, you may need sort of 0.3 to 0.5. If it's a giant breed, maybe 0.5. And that'll give you full limb anesthesia. Obviously, remember, that's probably going to give you a good 45 minutes of limb anesthesia, so remember that on recovery. But if you're going to do a lot of orthopedic work in there, you've got two choices. You've either deepened the anesthesia, at which point you may well be breathing for your bunny, because it is now apneic, because it is so deep that to keep it immobile on the table. Stop this withdrawal reflex every time you're manipulating the limb, or do a nerve block in that area, and then you can maintain a lighter plane of anesthesia, which may be better for the bunny, but still do the surgery you need to do on the limb. So, some things to look out for. Obviously, eye positioning in bunnies is not a useful technique for depth of anesthesia. Their eyes are huge and give them nearly 360-degree vision. They don't move the eye positioning. You don't tend to get a significant, you do get a corneal reflex, but because of the protruding eyes, it's quite difficult to ascertain that corneal reflex, that movement of the third eyelid. It doesn't tend to be like a bird where it sort of moves right the way across the surface of the eye. However, there are some things about the eye that you should notice. If you start to get ocular protrusion, that is really bad news. That's significantly increased vagal tone. You've got very high vagal tone at that point. You've almost certainly got a heart block. So, if hopefully the anaesthetist will have picked up on the slowing heart rate in the first instance or looked at the ECG. If you get to the point where the eyes are generally protruding, that's not good news. That does mean that there is profound vagal tone. There may well be something more sinister going on. Pulse oximetry. So this has been used in a number of different publications in bunnies, and interestingly, the same paper that looked at pulse oximetry looked at capnography in bunnies and tried to correlate it between SpO2 and SaO2 and tried to see what sort of correlation there was. To be fair, it was relatively small numbers, but the correlation was poor. So again, I use pulse oximetry in bunnies. However, I'm not entirely convinced that I rely on it, because a lot of them, particularly the cheaper models, have an upper limit, certainly for heart rates. So that's one thing. If you're dealing with a really small bunny, you may think you've got the most stable anaesthetic in the world because the heart rate is bang on 250 beats a minute all the way through. Maybe just the manufacturers, that's the problem with the pulse oximeter. It only reads up to 250, so it will just read 250 all the way through the anaesthetic, no matter what's happening with the cardiac rate. But as far as the actual SpO2 is concerned, going back to first principles, blood results, blood gases are a more accurate assessment of oxygen saturation. But we do use the central ear artery, and we do use the pedal vessels in bunnies. You may need to shave a little bit on the foot to get a good contact there. And certainly larger bunnies, if you've got a rectal probe, you can tape it to the underside of the tail and go for the coccygeal vessels in that area there. And again, we'd be expecting to see 97% or above. Remember, it's a sigmoid curve, dissociation curve, SpO2, and once you drop below 93%, you're getting significant hypoxia. So you start to get cyanosis of membranes, when you drop off the bottom of sort of 90%. So we need to have it in the upper 90s to be confident. But if at all unsure, and you do have a blood gas device in the practice, an iStat or an EPOC, then you may want to just correlate that with preferably an arterial O2. But if you can't, you can use the central ear artery if you're very careful and don't create a thrombus. If you create a thrombus, you might lose the ear tip later on. But if you're using very fine insulin needles to sample, you may be able to do that. If you don't want to do that, then obviously you can use venous, because yes, if your venous blood's at 100% saturation of oxygen, fine, great. You know, your oxygen levels are absolutely chipper. There's not a problem. Capnography, again, unfortunately, in this particular publication, suggested that it's not as accurate as measuring blood arterial gas measurements, and there was a poor correlation between end-tidal carbon dioxide and arterial carbon dioxide. So if you look at page 7 here, this was Eatwell et al. 2013. So basically their fundamental finding was arterial blood gas analysis was much more accurate. Ranges of arterial carbon dioxide of 25.29 to 40.37 millimeters of mercury, and arterial oxygen of 50.3 to 98.2 were considered normal. I would tactfully suggest that that is a wide range, and actually from my perspective, and certainly from my experience in this, that anything in a CO2 above 30, and I'm starting to be a bit nervous and jumpy about it, and anything in an oxygen that's below about 85, I would be concerned, okay? Really, if it's on oxygen and you've got it intubated, it really should be above 85 millimeters of mercury arterial oxygen, and the arterial carbon dioxide should be less than 30. 35 at the absolute outside. So I think a couple of these rabbits were possibly slightly hypoxic. It's the joys of small sample sets and all the rest of it. If we're talking about capnography, in most cases we're looking at side stream capnography. I think most veterinary capnographs are side stream because of the small volume of expiration that's going on with a lot of the smaller breeds of bunny that we use. The one thing to say about capnography is, I know that some people use it on face masks. Really, I'm not entirely sure how you interpret a face mask capnograph. That really doesn't make a lot of sense, because they're breathing room air all around it, unless you've got it so tightly welded to the rabbit's face that it's probably going to have a bit of ischemic facial necrosis afterwards. I'm not sure how that one works. So on intubation, absolutely. On face mask, I'm not sure that capnography makes any sense, with this caveat in mind that it's not that accurate, it appears, on intubation. So arterial blood gas measurement certainly is viewed still as the gold standard. It certainly is in dogs and cats, but we can get trends, and that's the important thing with capnography. We can look at trends. If we set our markers down at the beginning, and this is the same with ECGs, if we know what our rate and rhythm was at the start, we can mark that down. It's good practice to get your anaesthetist, or if you are the anaesthetist, to mark down exactly what the values were when you started the process. If you're plotting it on a graph, on a chart, then absolutely marvellous, that's grand. But just then periodically sample every 5 minutes or so and look at trends, because that can tell you more than anything else, even if the actual value is not 100% accurate. Rectal temperature, don't forget the basics. These animals often have a very large body surface area in relation to volume. If you've got an X-lap, then you've opened up the abdominal cavity to the room air. If it's the first op that morning and folk have not been in and turned on the radiators and it's a bit nippy in the surgery that morning, these animals are going to rapidly cool. So warmed fluids, often after X-laps, we'll put warmed physiological saline or warmed physiological lactated ringers into the abdominal cavity afterwards. It's quite a useful way of providing a little bit of hydration for the bunny on recovery. It also helps warm and keep everything up. So if you keep it up to 36 degrees centigrade, try not to obviously cook the bunny, but normal rectal temperatures anywhere from 38.5 up to sort of 40. Warmed IV fluids, sure, we can use those, but obviously don't forget radiant heat mats. These are the sort of reptile heat mats that you can get. A lot of the pressure heat mats will work for bunnies over 2 kilos, but often don't work for bunnies under 2 kilos. So remember, a lot of the green mats that we've got a pressure ones, they've got to have some weight on them to actually stimulate heat. So a lot of the light bunnies actually never generate any heat at all. So you may be better with a radiant heat mat, or going down the route of warm water circulating pads or things like bear huggers. Clearly the problem with those is losing your patient underneath all of the sheets and things that you've got the animal on. But even simple things such as putting tin foil on feet and ears. Sounds crazy, looks like the oven-ready bunny. Owners would probably freak if they came into the theatre at that precise moment in time. They freak because they see a bunny on the table, so that's going to happen. But the point is, these are areas where you're going to lose heat, ears particularly in rabbits, clearly. So actually do think about insulating those areas. If you're at all concerned about it, then it's worth wrapping your bunny well in order to reduce heat loss. I put this one in because this is clearly the future. Cerebral state monitors. So there are a couple of publications. So they've been used obviously in humans to produce cerebral state index scores, and obviously they've been used in dogs as well. We have a couple of studies in bunnies. Yin et al. Certainly showed a close correlation between the cerebral state index and the sedation score, and they suggested therefore that it would be a useful tool going forward, rapidly reflecting brain electrical activity, and isoflurane rabbits recovered faster than those anaesthetised with propofol, and that despite some cases showing limb movement during anaesthesia, there was no change in CSI. So if we want some comfort over this bit, because I know some people go, oh God, it's not anaesthetised when limbs move, and that is a worry, and I understand that, but actually we do have some hard science that actually backs that up with this cerebral state index monitor, as I say, which may well be the future of veterinary anaesthesia, or monitoring anyway, that the rabbits are still anaesthetised when they have this withdrawal. It is a spinal reflex in the case of this forelimb movement. Okay, what we'll do, we'll just do a little bit on rodent anaesthesia, and then I think we'll have a break. Were there any questions on rabbit anaesthesia?
We use quite a lot of just neat diazepam IV for sedation.
Yeah.
To effect,
Yeah. Okay.
Do you use that much?
Yeah, I've used it. I've not used it on its own. I've used it as a top-up. So, for example, where I've used a low dose of Hypnorm, so the 0.1 mil per kilogram, or a low dose, very low dose of medetomidine and butorphanol, so something like 0.05 mg per kg of medetomidine and maybe about sort of 0.2 mg per kg of butorphanol, because I've got a rabbit I'm a bit concerned about. I want a quick reversal, and then I've done that, and I've gone, oh, right, there's a tooth that just needs burred at the back of the mouth, you know, so always one of these dental ones, and you open the mouth up, you give them that little bit, and then you open the mouth up and go, oh hell, I've now got to burr that tooth, and it's not sleep enough for me to open the mouth up. A little bit of IV midazolam at that point, yes. So anywhere from I do it to effect, so I start off at 0.5 mg per kg, and you can go up to 2, and give it via the lateral ear vein. And the rabbit just then calms down enough to allow you to open the mouth up, and then but I wouldn't do anything obviously noxious, really noxious, not dental extraction or anything underneath that, because that's not anaesthesia. But enough to sedate the rabbit to allow a procedure, yes. I do find midazolam in particular, IV, quite useful. Rabbits respond quite nicely to it. The downside is you can try flumazenol if you can get hold of it. It's quite expensive and sometimes difficult to get hold of. You can try reversal, but it's not quite the same as the atipamezole reversal of medetomidine. You don't get like the instant reversal. The good news is that midazolam seems, touch wood, at those dosages to be incredibly safe in bunnies. They respond quite nicely to those sorts of tranquilizers, and I've not seen an issue with it. So yeah, useful drug, quite often just to deepen a sedation to allow maybe a procedure that's not a surgical one, but nonetheless needs that rabbit to be just that bit more relaxed.
About the prokinetics, how do you choose the patient to use the prokinetic before?
Okay, yeah, no, that's a good point. The short answer is purely based on history of patient in the first instance and what its presenting signs are. So history of patient, if I had problems in the past, okay, so that's fair. Presenting signs, if it's digestive tract related, it's problem, okay, so it's dental disease, and a lot of these bunnies are, then yes, I will consider using a prokinetic at that point. but I'll make sure, first of all, that I'm fully analgesed in the first instance. And my first line use of prokinetics will be metoclopramide combined with ranitidine. We'll talk about these a little bit later on, so don't worry, we'll come back to these. But my first line will be ranitidine and metoclopramide. I keep Propulsid, I keep cisapride, used to be called Propulsid, cisapride in backup for the cases that don't work. But routinely, I will not use prokinetics for like a castration or a spay. I will use good pre-operative analgesia. So we'll use our analgesics before, obviously, surgery. So standard one will be a non-steroidal like meloxicam, which seems to be wide safety margins. We'll use it at 0.6 milligrams per kilogram. So we'll use it at high dosages. Again, we'll talk a little bit about analgesia in a minute. If I think I'm going to be doing something more unpleasant to the animal, like an orthopedic op, then yes, I will consider using prokinetics in those cases because I know the pain is going to be higher. I'm going to be using other painkillers like buprenorphine. I may be using fentanyl, but therefore my chances of having post-op ileus is increased. So in those cases, yes, I will use a pre-op metoclopramide and ranitidine, and then we'll follow that on post-op with assisted feeding.
So routine surgeries, rather not.
I don't use it for routine surgeries where I think I can control the pain adequately. Yeah. It's the ones where you're just in that unknown ground. Sorry. Yeah.
We have epileptic bunny.
Ah, okay.
He comes in the practice and he is starting to do like his epileptic pain. And he has very bad teeth.
Okay.
So last time I started with Valium like subcutaneously just to get him calm, and then like isoflurane.
Yep.
Do you have a safer option in this case? We really have to do often his teeth, and I'm worried.
Yeah. I mean, I'd use midazolam. Midazolam would be the way that I would go. And yes, I would consider the difficulty is how you get these drugs into the bunny before it comes into the surgery, because I don't think there's any way that you can do that. So realistically speaking, on admit, I would give an IM injection of midazolam, and then obviously make sure that once that's taken effect, that I'm fairly rapidly then moving to anaesthesia. Gaseous induction, yes, you may want to give a little bit of butorphanol perhaps with the midazolam, and then go with a stepwise gaseous induction with something like sevoflurane. So that would be my personal choice. Minimize the number of other drugs that you're using. Avoid the alpha-2s if at all possible. But yeah, get a benzodiazepine in there absolutely as you're doing right up front. I think that's pretty much the only way that you're going to do it, and just it's about management of the procedure. So it's about having it, you come in to a surgery that there aren't a lot of barking dogs in, you're quickly seen, you're quickly dealt with, so it's timing. You may want them to get in, literally at the moment that you start to do your surgery cases, bring it in then, I'll see you, I'll do it, and then out and home. Keep smells. Does it have a friend? Does it have a pal? Is it close to that one? Because I mean, sometimes I've found some of these bunnies that you get their friend. I know, again, owners often push you to do this, and there's a sort of a sinking feeling where you think, I'm going to have to admit the entire household along with the rabbit. However, actually, they have a point, and having familiar, pals around them, and as well as smells, is quite useful, because it's the alien environment that they are olfactory beings as well as visual and auditory beings, and you put them in a strange smelling place that we can't smell the fact that there was a ferret in there last week, but there probably was a ferret in there last week and they're really stressed about it. That can help.
Yeah, and last time he was almost choking because with his crisis he swallowed something in his drink.
He's not a lion head by any chance, is he?
Huh?
He's not a lion-headed bunny by any chance. Oh yes, there you go. We will come back to my feelings on lion-headed buddies later on.
Thank you.
Beautiful animals, but unfortunately several genes short of a rabbit. Right, okay, rabbits, rodents, anaesthesia. So again, think about the pre-anaesthetic exam. We need, again, the reason why, and there hasn't been an anaesthetic survey that recently, the last one that was done did suggest a significant level of, in comparison to dogs and cats, of mortality associated with general anaesthesia in small mammals compared with, say, with dogs and cats. And The majority of these are almost certainly associated with missed pre-existing clinical conditions prior to the anaesthetic. The anaesthetist and surgeon were blissfully unaware of until the crucial moment. So if you have an animal that has a nasal discharge, it will have lung problems, okay? And these little hindgut herbivores, these guys are, you know, 2/3 digestive tract, 1/3 chest. Small chest space, limited lung capacity. Rats and mice, we know that mycoplasma is so common, Sendai viruses, and therefore significant abscessation in these cases is common. So they are potentially a risk. You may want, if there is any concern about this, to do other diagnostic tests or to put them on into antibiosis before you do the anaesthetic, okay? If the anaesthetic is postponable. We want to make sure that they are eating properly before they go through the anaesthetic. And when I say that, obviously a lot of these guys are presented with dental problems, so that's the problem. But we want to take maybe a day or two to push their energy balance into a positive phase rather than a negative, because all of these guys are very intolerant of diabetic associated ketoacidosis. A lot of them go into hepatic lipidosis. So they've obviously been perhaps plump, well-fed animals. This may have had an impact on the dental problem. They then get dental disease and pain. They stop eating. They go into a metabolic crisis. They are lipidotic. Take a blood sample. It often is, you can see the lipemia. Their livers are suffering. They are going into ketoacidosis. They are a high anesthetic risk at that point. So they're not a good candidate for doing that. You know what the problem is, but at that point, what you need to do is to take a day or two, or maybe longer, to stabilize them. Fill them with pain relief, rehydrate them, get their acid-base balance back onto normal footing, get the calories into them. Talk about this in the critical care side of things. Postpone the general anesthetic unless it is absolutely vital, and you will have much better success rates. There is one other thing. Guinea pigs always have food in the mouth. If you don't deal with, I'm sure you all do deal with guinea pigs. You're all, seeing guinea pigs on a regular basis. They can be one of the most challenging species to get through difficult times. They are, you know, adrenal glands covered in fur. They are intensely upset by just about everything. Life itself upsets them. And they always have food in their mouth. And actually a guinea pig, when you stick an otoscope in the mouth and have a look at the teeth, that doesn't have food in its mouth, that one is the one that should set the alarm bells off, because what should come towards you is a wall of pea soup. So they are actually a little bit of a problem, as we'll see in a minute, when it comes to maintaining airways. But we don't fast these guys. Even the omnivores, even the little mice and rats and things, because of the high metabolic rates, starving them, gut transit times, literally just being separated from the food in the period from coming from home into the clinic and waiting until they're actually anaesthetized is usually enough. We don't generally tend to recommend that you starve them for any length of time, and herbivores not at all. There are a bunch of pre-anesthetic medications that have been used, and some of these are useful and some of them not. We have this question mark over whether or not hindgut fermenters like guinea pigs and chinchillas and degus also have atropine esterases. There's a little bit of evidence that they do. However, there is an awful lot of evidence that atropine seems to work. And I use atropine quite regularly in chinchillas and guinea pigs, which is ironic, seeing as I don't use it in rabbits. And we don't tend, it seems to ablate heart block, which again is a very, very common dysrhythmia. So with most of these small guys, heart block is the dysrhythmia you are most likely to see. And atropine does seem to work in hystricomorphs. I don't quite understand why. It may be because they're South American, and that is a lack of exposure potentially. I'm not a botanist, so I'm not familiar with the flora of South America enough to know that atropine is maybe not a common component of plants' defensive mechanisms in South America. It may not be. But atropine does seem to work. However, you're going to have glycopyrrolate knocking about in your bunny crash box. If, for whatever reason, you're not getting the desired response with atropine, I'd move to glycopyrrolate just to be on the safe side. There is relatively little data about there. But I use atropine quite routinely as a pre-med in guinea pigs and chinchillas. Why? Well, because the main reason that I'm seeing these guys is for dental problems, and they usually salivate badly during anesthesia, particularly if you're using gaseous anesthesia Chinchillas just drool continuously. And the atropine's quite useful at reducing that, making your field of vision easier, as well as having that other important cardiac stabilizing effect. Promazine, not used so much. Hypnorm certainly has been used, we'll see in a second, but Promazine not used so much because of poor reversibility, again with the rabbits, although it's quite a nice tranquilizer. But there is a big issue associated with animals that are prone to idiopathic epilepsy, particularly the gerbil, that Promazine, and there is some debate about this now in dogs as to whether it does lower the fitting threshold, but certainly I would try and avoid it. It's not a particularly useful pre-med. For other species, benzodiazepines, diazepam, midazolam, these work quite nicely in a lot of the small furries, particularly those that get quite stressed, so the Cricetidae. Gerbils, again, because of their predisposition to seizuring, then low-dose midazolam or diazepam can be useful in these species to reduce the incidence of seizuring, and particularly if you've got an individual that is prone to that, it runs in certain family lines in gerbils, then I would always try and pre-med with a benzodiazepine if you have to do anaesthesia. Hypnorm is actually technically licensed for sedation. Mice, rats, rabbits and guinea pigs, is used at a full 1 ml per kilogram body weight in guinea pigs combined with midazolam and or diazepam for general anaesthesia. There's some data in the notes there, but can be used at a fifth of that concentration as a pre-med, and is quite useful in guinea pigs to ablate breath holding, because my favoured general anaesthesia in guinea pigs is to pre-med them with Hypnorm and atropine, and then to give them a stepwise induction with oxygen and isoflurane. We mentioned ketamine and xylazine in the notes, and it's mentioned again, but again I would avoid its use. I think this is older textbooks that are still quoting it. You sometimes find it in papers and reviews. Again, xylazine is not easily reversible. We know that it can cause myocardial hypoxia. Ketamine and medetomidine as a combination in itself, you'll see there's a whole series of dosages here that have been published. So some of them really are quite high. So intramuscular or intraperitoneal in rats, mice and hamsters requiring 100 to 150 milligrams per kilogram of ketamine and 5 mg of xylazine. And if we're talking about medetomidine, 0.5 mg per kg of medetomidine, with ketamine dosages usually around about 50 milligrams per kilogram. So these are quite significantly increased dosages. I must confess that in the majority of these guys, I find much lower dosages, depending on what it is that you're wanting to do to the animal, are more effective. And so, for example, in chinchillas, for dental procedures, then typically the pre-med will be something like midazolam plus atropine, and that can be given subcut. And this again brings us back to the thing with small furries about dosing. If you're using an aqueous solution and the animal is well hydrated, subcutaneous injections are usually better tolerated than intramuscular, and actually tend to be absorbed at pretty much the same rate. It is marginally slower, obviously, but to be brutally honest with you, it is a minute here or a minute there. So the caveat is obviously that they're well hydrated, but they're usually better tolerated. So we tend to give a midazolam and atropine pre-med, wait about 15-20 minutes or so, and then give medetomidine plus ketamine. And typically speaking, we're giving a dosage of 0.02 mg per kg and 2 mg per kg. So 0.2 mg per kg medetomidine and 2 mg per kg ketamine. So it works out as 0.01 ml of your standard favoured medetomidine drug and 0.01 ml of your favoured ketamine combination, subcut, will produce enough sedation to do x-rays, to have a quick look around the inside of the mouth, and potentially maybe even enough to burr a tooth or two, with minimal cardiorespiratory effects. So it is really low dosages. So a lot of the published dosages, just when you're looking at them, it doesn't tend to help you much because you look at textbooks, and we all do, and formularies, but it is worth checking out some of the references, particularly in things like Carpenter, very useful formulary, the Exotic Animal Formulary. They very helpfully give the references, and you can go back and have a look at those references in the oodles of spare time that I know that all of you have, and have a look at A, how far back it was in time, and B, also what it was they were doing and what the success rates are, because some of these things you read the abstract and then you miss the bit that half of them died during the procedure, because that bit was kind of scooted underneath the carpet. It's like the ones of the intranasal rabbit thing, you know, you have to actually read the thing to find out that actually some of them died when they put them in dorsal recumbency. All the bits in the abstract is, this works, you know, hooray, some of them died. So it is worth thinking critically about these things. If you want to do something surgical, something painful, then this is not enough, and you are going to have to give them either additional gaseous anesthesia, so isoflurane or sevoflurane, or you're going to have to use higher dosages of this. So typically increasing this to maybe 0.05 and maybe 5 mg per kg, and that usually allows dental extractions and things of that nature. Depends how debilitated your chinchilla is, but again, it's about not rushing in and doing something when the animal is in a critical state. It's about stabilizing the animal in the first instance, gives you better chances of a successful outcome with the surgery. So ketamine and medetomidine, there are lots of recipes, combinations that are published in the notes, but I've given some in there. I used to use ACE Promazine with atropine with chinchillas, and I've moved to Midazolam, and I find it slightly better. So you will see, I think I've written in the notes there, ACE Promazine. Having said I don't use it, but I did used to in chinchillas. It seemed to work in them for some reason, but actually I think Midazolam is better. So I've moved to Midazolam with these guys. 0.5 mg per kg. So it's quite a low dose. You can go up to 2 mg per kg for seizuring activity, and that's something. This is 0.5, so it's quite a low dose. But it just takes the edge off the chinchilla, makes it quite relaxed. And then again, particularly when we're dealing with alpha-2s, we don't want wind up. And a lot of these animals, the reason why if you just barrel on in there with an alpha-2, you sometimes don't get the desired response you want to, is because the animal's been wound up severely. And we know this in, you know, domestic cats and dogs. You wind them up and the medetomidine ketamine doesn't work. So it's exactly the same for these guys. Problem is these guys don't show you they're wound up. They just sort of sit there and, you know, literally the rabbit in the headlights. Inhalation anesthesia certainly is my favourite if we're talking about anything surgical, so neutering, any sort of orthopedics, anything like that, then I will certainly induce the anesthesia, pre-med the animal with drugs like fentanyl fluanazone, maybe low dose medetomidine ketamine or a midazolam atropine combination. But then I'm going to go with a stepwise induction with oxygen and gaseous anesthetic. Isoflurane is fine. Sevoflurane is good, certainly for debilitated ones. I will use one word of caution. Is anybody using sevoflurane in guinea pigs on a regular basis? Yes. How do you find it?
I know that when I think there's apparently quite a lot of anesthetic mortality in
Yeah.
guinea pigs.
Yeah, it's not. Yeah, it can be used. Okay, so there's no two ways about it. It's not a case of it's a bad anesthetic. It's not a bad anesthetic. The problem is that you have to understand with the physiology of the guinea pig is that the guinea pigs at the depth of anesthesia that you need with sevoflurane to do something noxious to the guinea, I mean really noxious, like surgery to a guinea pig, is often at that critical level where the guinea pig gives up breathing. That's the problem. And because we have a problem with intubating guinea pig, if you can intubate your guinea pig, it's not a problem, because then you have control of the airway. The problem is the anatomy of the guinea pig that makes it difficult to intubate. So if you thought rabbits were a challenge, guinea pigs are absolutely a challenge. Not impossible, but they are very difficult. And they're difficult for two reasons. The first one is the pea soup. So you have to spend some considerable period of time during the induction process sticking cotton buds in the mouth and just removing all that pea soup from the mouth, because there's no point in sticking a tube through the oral cavity covered in all that lovely gunk and then pushing it into its trachea. That's obviously going to be bad news after the op. The other problem is that they have this thing called a palatal ostium. So a palatal ostium is basically, if you look into the mouth of your G-pig, at the back you can sort of see the soft palate, and then you can see the underside of the epiglottis. Okay, so you've got teeth here, you've got the smooth pink back of the mouth, and then you've got this arch, obviously, which is the underside of the epiglottis trapped behind the soft palate. Okay, so that's similar to any other animal. The problem is that there is a little bit of bone in here that holds that in place, so they are almost locked. It is possible to unlock it, but only at the tip. If you try at the sides, it's actually very, very difficult to get round it. So you literally have to poke your ET tube in at this point here midline, and then force down the epiglottis to insert your ET tube into the trachea. So it requires a bit of effort. It's much more difficult than a rabbit, where a rabbit, you just push on the soft palate and the soft palate flips above the epiglottis, and the epiglottis just drops into view, the whole of it, and it's there, and you can put the ET tube in. With these guys, it's a case of you actually have to kind of almost push it over the top to get it into it. It is possible to do it, but again, narrow, small oral cavity. You're going to need a long Wisconsin zero blade or one of these rabbit laryngoscopes. You're going to need to make sure the animal is properly anaesthetized before you do it, because it's going to be stressful to do this. You need to take time to remove the pea soup from inside the mouth, and then you have to go for the intubation. So they are a challenge. If you've got a really long op, or you've got a difficult critical case, it is worth doing. However, certainly in guinea pigs for routine ops, I have historically used just face masks, and in that case I will use isoflurane, because we don't get that same narrow margin of apnea at the right depth of anaesthesia with isoflurane as you do with SIVO. So it's not a case of SIVO is bad. SIVO is very good with mammals, and it's very good with debilitated ones. It is just slightly problematic when it comes to guinea pigs, because if you don't have control of the airway, they stop breathing, then where do you go? The other things obviously that you can do with the G-pig to make life easier for you is remember again the anatomy and have it on a tilted table or a slope. Okay, and this helps with bunnies as well. So if you're putting it in dorsal recumbency in order to do a spay or a castrate, then you know, have the head end up. Let the guts fall away from the diaphragm. The diaphragm breathers, get the weight off it. Okay, so do, and obviously during the op, periodically, you know, the anaesthetist should be checking it, because there's a sort of slump that sort of occurs during the op. They sort of need to be sort of gently pulled back up the slope again. So a tilting table usually is better for these things. So yeah, so be aware. Sevoflurane can be used, but it's got a narrow safety margin. I know I'm fairly happy in saying that, as I say, because I've spoken with Paul Flecknell about this on many occasions, and he's broadly in agreement with that, that it is about the depth of anaesthesia that you require with SIVO to do surgery. You can immobilize them for radiographs and things on an oral exam, not a problem, because you're at quite a light plane of anaesthesia. But then try and, you know, use a scalpel, you're going to need to deepen them at the point at which they may well become apneic. Again, circuit-wise, we're looking at small, low volume dead space, mini Bains, potentially Mapleson Cs, these sorts of circuits, because we don't want lots of dead space that's going to significantly cause a rebreathing effect. Yeah, so recumbency, as I say, make sure that they are sufficiently pressure's taken off the diaphragm. Do be aware that, you know, if we're spaying something the size of a Jungaran hairy-footed hamster like this, you know, the body surface area to volume is enormous in these little guys. So consequently, we do need to make sure that they're dramatically perched on a hot hand, no, they're on some form of heated mat, preferably radiant, because there's not going to be enough weight to actually trigger a pressure sensitive one. We're going to need to be in an ambient environment that is you know, mid-20s. We want to be using warm fluids, and we want to be speedy with our surgery and do minimal surgical scrubs. So, you know, we're not, and certainly avoid surgical spirit to avoid anything that's going to cause significant evaporative heat loss in these guys. Minimal scrubs, minimal clips, quick surgical times. Again, putting warm fluids back into the abdominal cavity if you're doing exploratory laparotomies to keep the core temperature up. These are all important. As far as monitoring anaesthetic is concerned, then we have relatively few features that can be used to accurately monitor. You can, for the larger ones like guinea pigs, you know, do ECGs on these guys with sticky pads on the feet. Again, heart block is a common feature with them. Pinch reflex is typically used. We don't tend to see the forelimb issue that we see in lagomorphs in most of the rodents. Eye position is not useful again with these guys. Interestingly, just ketamine or ketamine combinations, palpebral reflexes tend to be maintained in a lot of animals. And actually with ketamine medetomidine low dose like this, when we're doing dentals in chinchillas, the good thing about that, apart from the fact that it tends to be have relatively little physiological impact on the animal, is that they maintain a slight swallow reflex. So if you're doing anything dental wise and you're potentially putting saline-soaked swabs in there to bird a tooth or something, you're trying to keep the dust down inside the mouth, actually they have a swallow reflex. So if anything does lurk its way to the back of the throat, then actually they will swallow on the back of that. But for deeper anaesthetic, we have limited physiological reflexes that can be used. In guinea pigs again, if we're using capnography, end tidals of about 30-35 millimeters of mercury typically are the kind of levels that we're wanting to aim for. With these guys, intubation is just not, certainly not possible in the Russian hamsters. It is technically possible to intubate rats and some of the larger mice. They are an incredible fiddle, and you have to adapt IV catheters, and mostly we do them blind. So we're again adopting the same technique that we're doing with rabbits, of picking them up, having them sternal recumbency, picking the head up, and using a fine IV catheter midline to run across the hard palate, down the soft palate, and if it's midline, guiding into the trachea. But they're not easy to do this with, and the vast majority we do on face mask. So we are taking a calculated risk, which is why it's so important to make sure that their health going into the anaesthetic is optimal. I think what we'll probably do is we'll have a caffeine break there, because that's quite a session that we've looked at. Were there any questions initially on that before we get to the end? Yeah, Karen. Yeah. Yeah. Yeah, I mean, it is a difficult one, and I guess that, yeah, the issue is I would go to Burton's or go online at one of the auction sites and pick up 50 quid's worth of Isotech and just keep a bottle sitting in the back of the. It comes to reptiles as well. You'll find that some reptiles, if you're just using gaseous anesthesia, phenomenally difficult to maintain anesthesia just using sevoflurane. So we find this with leopard geckos, with bearded, well, not bearded dragons so much, leopard geckos, and some species of snake can be very, very difficult to induce, certainly with sevo. They just don't breathe fast enough to keep it in the body system. And we believe that there's a shunting mechanism, which is an interesting one. We come on to reptile anesthesia. There is some recent data that suggests that other drugs may be able to influence how well some of these gaseous anesthetics work. Yeah, I would personally stick with the isoflurane, because the problem with the injectables is, yes, you could use Medket in G-pigs. I personally would prefer to use Hypnorm plus Midazolam, because that one has been around for a long period of time. There's a lot of data on it. It's very safe. But once you've given the injectable, it's phenomenally difficult to then reverse the anaesthetic. You can't reverse the ketamine, you can't reverse the fluanazone, depending on what you're using, and at least with the gaseous you have full control. So yeah, I go with the isoflurane. You can use SIVO, I think, for the minor procedures, and you may be able to do that with a combination of local anaesthetic blocks and things, for things like castrations, and maybe some midazolam pre-meds. You may get away with minor procedures. I think when you start to get to things like orthopedics and you're doing more serious involved ops where you need a deeper level of anaesthesia, they just stop breathing. And that's the problem, and then you've got nowhere to go unless you intubate. So that's your other option, is stick with the SIVO, but then spend a bit more time working with them to get them intubated.
Have you come across the V-gel guinea pigs that are?
Yeah, we've seen a couple of initial ones there. The problem is insertion. And yeah, it will be very interesting to see that if that comes through. You're still not removing the soup in the mouth issue, which you need to spend a bit of time removing. The other problem is the insertion is actually getting it to the right point. Because getting that epiglottis fully into the oral cavity is incredibly difficult to do. And you don't want to be too rough, because when you look at it with the laryngoscope, it's surprisingly well vascularized. So you're looking at it and you're poking around at this thing, and it's, it's going to bleed any second. I have had a rabbit have a significant epiglottal bleed because it was blind intubation and poked too many times. It was okay, but it's kind of scary when the back of the mouth fills with blood and you kind of go, that's not a good place to be. So yeah, I mean, I hopefully, watch this space, that there will be something that will be useful that will come out of that. We'll talk about with critical care, actually in a lot of cases with these emergency ones, in a moment of, blind terror as the thing is crashing in front of you, actually going straight in and doing tracheotomies is the easiest route, with an over-the-needle catheter, or in the case of rabbits, just doing a cut down. They're easy. They're really easy. And if you've got a life and death, I can't intubate, right, just do a tracheotomy. And even in rats with a hypodermic, straight in, and then you can connect it via, these little ET tube connector sets that you can buy, which are the bane of everybody's life because they always fall across the floor of the operating theatre. Nobody gets them back in the right holes. There's always the one that you want is missing because it's on the end of an ET tube somewhere. You never find it in the moment of crisis. Right, I think we'll have some caffeine, if that's okay, and then we'll be back in 15 minutes. Is that all right? Lovely.